is better for B than for A, meaning under ideal condition, everybody complies. Now, the problem is that even though A has a higher mortality, it has more compliance. Compliance is much higher than in B. So when you look at those joint probabilities, okay, for example, just to give an example, what is the joint probability of that in people who comply, belong to a high social class, they have this mortality? Just multiply those percentages and you get 7 per thousand. And it's another example. You take each path and you calculate the joint probability of that, which is very straightforward, right? And then you sum all those joint probabilities for each one of those paths. And what you see in program A is that the mortality, total mortality is 28%. In program B is 37%, even though in people who comply, the mortality is less. And this is, so what is the conclusion? The conclusion in program B has greater efficacy, which is low mortality in compliance. But because compliance in A is higher, its effectiveness is higher than that of B. Okay? So the question is, how can we improve the situation? Okay, suppose that program B is less expensive than program A. So you could do a sensitivity analysis and say, what would happen if program B had a higher compliance? And maybe you can put some procedures into effect. For example, for a medication, a chemotherapeutic agent, like to pay my homage to Dr. Nichols, who is sitting right there, who studies, survival. So if you have a chemotherapeutic agent that causes a lot of nausea, or say the compliance is not high, so maybe you can come up with some medication to diminish the nausea. So you can ask the question, it has to be reasonable. So the question is, what will happen to the total mortality associated with program B if its compliance increased to 50%? It's a reasonable question. It wouldn't be reasonable if you say if the compliance increased to 100%. That would be tough. Go from 30 to 100, but from 30 to 50. So what you do, you recalculate those values. And when I recalculate those values, this is what happens. Well, A is still A, same thing. But B went down to 29.7. Before, it was 37.8. Okay. So, conclusion. Total mortality is still a bit higher for B. But if B is less expensive, it may be cost effective to implement B. So this kind of exercise, you need a health economist, of course, because from here on, you have to calculate cost effectiveness, which is outside the realm of epidemiology. Okay. And I think I'm afraid that I have cut too many slides because I only have a few slides. But that's okay because I gave you the essence of my talk. And I really like to have some discussion. So let me finish. Oh, this is a decision tree that I did. Incidentally, a decision tree doesn't have to be comparing two programs or two medications. It may have only one decision node. For example, here for hypertension, the decision node is drug therapy. It's offered to all patients who have hypertension. However, some accept the drug and some don't. So some comply and some don't. And for each one of those groups, some people have their hypertension controlled, yes or no. Now you may say, how come people don't accept the drug therapy, their hypertension is controlled? You may have lost weight or whatever, exercise or change their diet and so on, or remove a stressful situation. So you can calculate, again, for each path, you can calculate the joint probability of developing coronary heart disease. And the overall incidence would be 8.5, but if you look at acceptance of drug therapy, for those who accept, the incidence is 3.7 per thousand. For those who don't accept, it's 4.9 per thousand. And the thing about effectiveness you have to keep in mind is that it is specific to each population, each target population. So the external validity of effectiveness is dependent on the characteristics of the population. So theoretically, I know this is a remark that is open to discussion, but theoretically, efficacy has a better external validity than effectiveness. Because for effectiveness, you have to study almost each population. Now, a few years ago, the health ministry in Brazil, from where I come, nobody's perfect, right? So he asked me to design a clinical trial of smoking cessation. There have been many clinical trials of smoking cessation, but people in Rio de Janeiro are not like people in Baltimore and North Carolina. I mean, it's hot, and the patch, nicotine patch, may cause skin reactions to a greater extent in Rio than in, say, New York, and so on. So we decided to do that, and very disappointing. After 1 month, the experimental group, the group that had received the intervention, it was an open trial. We didn't have placebo. In those times, there was no electronic cigarette, so I couldn't have a control group. But in the first month, after 1 month, the cessation rate was much less in the group that received nicotine patch. After 1 year, there was no difference. So cessation of smoking is a real tough issue. I think it's much better to do population policies like the United States has done, prohibition of indoor smoking, et cetera, et cetera. Okay, let me finish my talk by just emphasizing some differences between translational epidemiology and academic epidemiology. And I really think that compared to maybe 50 or 60 years ago, most epidemiologists today are involved in etiological epidemiology, study of mechanisms, which I think is terribly important. I'm not underrating those things. But I think the balance has to be restored. I think we need to go back to epidemiology for public health. We need to pay attention to these differences and see if we can do anything to restore that balance. Now, in translation epidemiology, focus is application. And you can say, well, even in etiological epidemiology, the focus in the long run is application too. But in translation epidemiology, the focus is not application in 50 years. It's more like short-term, medium-term. Whereas in academic epidemiology is etiology and mechanisms. Translation epidemiology favors measures of association based on absolute differences, attributable fraction, and thus focuses on additive interaction. Whereas in academic epidemiology, the focus is on relative measures of association, relative risk, hazards ratio, and so on, and thus the focus is on multiplicative interaction. In translation epidemiology, public health confounding is useful to identify high-risk groups. And incidentally, this depends also on the prevalence of the confounding factor, okay? Because the confounding factor doesn't exist in that population. It's almost like mass adjustment, like matching. You don't have that stratum. Whereas in academic epidemiology, etiological confounding is a bias. Translation epidemiology favors effectiveness, real-life settings estimated by decision analysis. Whereas in academic epidemiology, the focus is on efficacy, usually estimated by randomized clinical trial. Although I'm more or less convinced that even good randomized clinical trials don't give us pure efficacy. There's always some loss to follow up, crossovers, and so on. So what we call ideal condition is not really ideal, okay? And I just wanted to give you a phrase from one of my mentors: if it isn't ultimately aimed at policy is not worth it. It's exaggerated. I just want to emphasize the importance of public health, epidemiology for public health. And thank you very much. Questions?
What
That's why, one of the slides I showed, there's this tension between obstacles and policy recommendations from the scientists. I don't know, unless we get involved in a discussion about politics in the United States and elsewhere, it's really complicated because once, let me talk about my native country. In my native country, Brazil, it has lots of problems. We all know corruption, violence, etc. And the Brazilians would say Brazilians as one of the problems. But the one thing that is good is that the Ministry of Health is very focused on prevention and has a strong association with the academia. So let me give an example. I got a competitive contract from the Ministry of Health to study. They wanted to study metabolic syndrome, and I convinced them to study risk factors in general in adolescents because obesity and overweight the prevalence are increasing enormously in Brazil. So there may be 25 to 30% of adolescents are either overweight or obese. And they want to use this study, and so they give me money to do a big study. It's a survey. It's not exciting like some of the etiological epidemiology that I do in the United States. But we'll have a lot of descriptive data, and we'll be able to look at the cross-sectional association. And they want that as an ammunition to take to Congress and show slides and show posters and so on, which I don't think is happening in this country. I mean, you have to lobby. I mean, the very conservative people, the very anti-public health people, let's say it this way, they have a very strong lobbying strategy. We don't. I mean, and I think that has to change. So they will use that. Actually, I was in a meeting of the health ministry with about 800 health secretaries of all over the country, in which I showed some preliminary data. And they came to talk to me about, what they plan to do and so on and so forth. Something simple like snacks in schools. I mean, that the students now get pizza and hot dogs. So that's the situation. It depends. I think it varies from country to country, I suppose.
On the point you made on the distinction between efficacy and effectiveness, you said even for the trial, we often have problems and don't get efficacy. And I think that it might be an impossible target. There's this idea of efficacy, but in reality, there is no true causal effect. And so the search for it may ultimately lead the academic epidemiologist back over to the left. Because when I was looking at your columns, it seemed like the left-hand side, which was the translational epidemiology, resonated even with me, and I think I'm largely an academic. I wonder if
Actually, I am too.
Have you seen that? Have you noticed a trend, a change in that direction, or no?
In translation of one. Yeah, actually, I gave a lecture at the Harvard School of Public Health, and I had a discussion with Donald Spiegelman is leading a group that is discussing translation epidemiology, how to set up a program and what are some ideas for even research and so on. So at Hopkins, as you know, we created a professional epidemiology. We call it I wanted to apply, but we decided on professional epidemiology, which is actually applied epidemiology. And maybe some of those notions are going to be discussed. So I think people are realizing that the balance has to be restored. But basically, most schools of public health, what we all do is really etiology, mechanisms, causality, and modeling, which is good. I mean, it's crucial. I mean, it's important. I don't think they compete. I think it's a matter that, I think both have to do that. Both philosophies, I would say, have to do that. times there was no PhD in epidemiology. And I said to Dr. Liebenfeld, who was the chairman of the department, how come, I did my doctorate, I did a study, I learned about regression, beginnings of regression back in the 19th century. And how come I never saw a health department? I had no idea of what they do with epidemiology. I mean, what epidemiology does the Department of Health in Maryland, the state of Maryland, or the city of Baltimore? What do they do? I have no idea. I have a doctor of public health. I've never seen a public health clinic. I don't know anything about vaccination and so on. And he said, yeah, this is something we have to follow. And finally, 50 years later, it was 40 years, now they have a professional epidemiology program.
Thanks so much for the talk. I had an academic job for 20 years or so, but I don't think of myself as an academic epidemiologist either. I just wanted to ask you about, I guess it's just a rhetorical point, but this term translational epidemiology. I mean, I came up in a regulatory setting where people actually make decisions, and we called it risk assessment. And it just seems to me that the translational epidemiology focus is still too academically centered. It's like we do these studies, and then we look around and see if there's some way we can translate them, maybe to help policy. But it starts with the studies, which often are done for ideologic purposes. I like to think of, when you said applied epidemiology, that's the term I would use. And why don't we start with the policies, the policy options, the things people are contemplating actually doing at regulatory agencies or corporations or whatever, and then design our studies so that they will inform them, rather than doing our studies and then wondering if we can translate them into help policy.
You said that a couple of bars ago. You should work with the, actually, that's what happened with the Ministry of Health, the example I gave. You're concerned about the obesity in overweight. You wanted to do something about it. So they asked me to do a study because we don't know exactly. We just feel that obesity and overweight are increasing in the West. I agree 100% with what you said. Well, as to the terminology, yeah. But I think he's right. I think epidemiologists who are interested in public health, they ought to work with health policy.
Well, I don't think the terminology, if you change the terminology, it might have an effect on the thinking, but if we change the thinking, we might change the terminology. I mean, you're very close to Washington and to Rockville and Bethesda. We're kind of halfway between there and Atlanta, but those are places where No, I'd be asking people and organizations that can make decisions, what decisions they're contemplating, then I would maybe design the study that could inform that.
Yeah. Although, sometimes what they want is not really the right thing to want. So we have to also,
Could you elaborate on that?
Well, yes. I mean, Obama now, this big initiative of personalized medicine, okay, it's all dandy and fine. Now, remember the United States now is facing an epidemic of measles, which is a completely controllable, eradicable, I don't know if that word exists, disease. And I think primary prevention is not mentioned by anyone. Everybody's afraid. The Republican because it's freedom of choice. Democrats because lots of people they vote for Democrats, whatever. But yeah. So some of the things that are proposed by health policy people, because obviously there is a group that helps.
Thank you.
When you're doing the study in Brazil now, or have you already done it?
Say it again.
You said you were doing a study in Brazil on obesity.
I finished it. The data collection has finished.
And was the data collection done separately from northern Brazil, Salvador versus Rio versus Sao Paulo?
We had a random sample of all cities with 100,000 people or more. So the study is not, the sample is not representative of states or cities, but it's representative of regions, north,
Right.
east, south.
So you made different conclusions then, given
We have
the
not analyzed
huge.
the data yet.
Oh, okay.
We just finished data collection maybe a month ago, so we're cleaning the data and so on.
Well, let me put it this way. You expect to make different conclusions based on the fact that the ethnicities between those three regions in Brazil are huge.
Not just ethnicity, but the culture, the local culture.
Same
is
thing to
quite-
me,
yeah,
but yeah.
it's quite different. That was a challenge in terms of, for example, the diet
Right.
questionnaire, because different regions have different habits, dietary habits.
So I invite everyone to continue discussion with Dr. Szklo at our reception outside, and thank you again for.